Hello, my name is Zhou, and I am a surgery resident at Baystate Medical Center. I will be discussing a study on the outcomes between laparoscopic and open appendectomy in the setting of coagulopathy using the ACS-N database. I performed the study with Vita Rastegar, our statistician, and Dr. Al-Mansour. Vita and I have no disclosures to discuss. Dr. Al-Mansour has several education and general payments to disclose from Intuitive, Gore, and Duvall. This study came about after we noticed that more of our patients were older and more frequently on anticoagulation and antithrombotic medications. In patients who require emergency surgery, reversal of all anticoagulation and antithrombotic therapies may not be feasible. There have been multiple studies in the past that have shown laparoscopy to be a safe approach in emergency cholecystectomy and elective hernia repair in the coagulopathic patient. However, there is limited data evaluating the different operative approaches in patients with appendicitis. We therefore sought to answer this question using the ACS-N database. We used the national database to identify adult patients with coagulopathy and the diagnosis of open or laparoscopic appendectomy using the appropriate CPT codes. Coagulopathy was defined as either having a pre-existing bleeding disorder or abnormal coagulation labs, including platelet, INR, or PTT levels. These cutoff values were based on those used in existing trauma literature. Patients with concurrent procedures were excluded. Our primary outcomes were rates of postoperative transfusion within 72 hours and 30-day unplanned reoperation. Our secondary outcomes included operative time, hospital length of stay, and surgical site infections. For our statistical methods, a complete case analysis was performed, meaning that all patients who missed any covariate data were excluded. Given our large N, the exclusion of these patients would not be statistically significant as the missingness is presumably random. Furthermore, we anticipated baseline differences between the patients who underwent open and laparoscopic appendectomy. Therefore, we used augmented inverse propensity weighting to correct for this difference. AIPW combines two regression models, one for the propensity score and another for the outcome variable. This essentially allows for a doubly robust regression model and treatment of the data. A propensity model was developed using 23 variables. This is a table representing the baseline differences between patient demographics along with the standard difference before and after treatment with AIPW. It is a rather busy table, but I will highlight some of the relevant findings. Of the 7,049 included patients, 784 underwent open appendectomy. The vast majority, 89%, underwent laparoscopic appendectomy. Patients who underwent open appendectomy were much more likely to have a higher ASA class, higher rates of sepsis or septic shock, and a higher proportion of dirty or infected wounds. They were also more likely to have preoperative acute kidney injury, preoperative transfusions, and a host of other medical comorbidities, including severe COPD, CHF, and end-stage renal disease requiring dialysis. Based on these significant preoperative differences, our statistical analysis therefore relied on AIPW to correct for selection bias and make meaningful conclusions. After AIPW, the standard differences between the two groups were minimized, which can be seen in the rightmost column. This table summarizes our primary and secondary findings, outcomes after AIPW treatment. Again, this was used to minimize selection bias, considering the differences in baseline characteristics between the two groups, which we were able to appreciate from the last slide. There was no difference in adjusted risk between laparoscopic and open appendectomy and the rates of postoperative transfusion or reoperation within 30 days. With regards to the secondary outcomes, the laparoscopic approach was associated with shorter operative time, shorter hospital length of stay, and lower surgical site infection rate. There was no difference in 30-day readmission or mortality. Our data shows that laparoscopic appendectomy is the most common approach in patients with coagulopathy. Our data also corroborated several previous studies that established the advantages of laparoscopic appendectomy, including shorter hospital length of stay and lower rates of surgical site infection. These advantages were also seen in the coagulopathic patients included in our study. There was also no difference in postoperative transfusion, reoperation, readmission, or mortality. Some of the limitations of this study are inherent to using the ACS-NSQIP database, including short-term follow-up of only up to 30 days, specific to the operating hospital. NSQIP also does not capture the rate of laparoscopic to open conversion, but presumably these would be coded as open procedures. With the advent of oral anticoagulants that do not always affect coagulation blood work, we may not have accurately captured all patients who are on NOACs at the time of surgery. A high-quality randomized control trial is needed to help further guide the surgeon's approach in the management of this complex subset of patients. I would like to thank Dr. Mazen Al-Mansour, who is my attending and research mentor for this project. He's now at the University of Florida. Vita Rastegar was also instrumental for the statistical analysis portion of the study. Thank you for your attention.